So good afternoon and welcome to everyone. I'm Gráinne Healy and I'm delighted you've joined us for today's webinar. This Sláintecare webinar is the 21st webinar in the series, and we are delighted to be delivering this session in partnership with the HSE. As always, we are very happy to take questions or comments from you, the viewers. Just use the chat function and I will convey your remarks or questions to the panel of guests with us this afternoon. Sláintecare is about the right care in the right place at the right time by the right team. We are focusing today on a mental health project which is providing community-based intensive multidisciplinary team interventions to service users and their families and loved ones at a time of mental health crisis as an alternative to mental health unit admission. This team that we're going to look at today is led by consultant psychiatrist Dr. Elizabeth Gethens. However, before we go to Dr. Gethens and hear all about the crisis resolution team, I am delighted to start our session this afternoon with a message of support from the Minister for Health and Older People, Mary Butler, TD, who wanted to speak directly to you, our viewers and attendees, as we focus today on her portfolio, which is mental health.
Hello everyone, I'm really pleased to open today's webinar showcasing the HSE Crisis Resolution Teams for Mental Health. So in May of this year, I launched the HSE Crisis Resolution Services Model of Care in Sligo. It represented a significant step forward in the provision of targeted mental health supports for people experiencing a mental health crisis. It also fulfills a long-standing goal aligning with service of the recommendation in Sharing the Vision, our national mental health policy. Sharing the Vision is a 10-year plan which was launched in 2020 and places mental health policy centrally in the development of Irish healthcare. It recommends a whole of government, cross-sectorial and population-based approach working to meet the needs of individuals at the appropriate level over their whole life cycle. Sharing the Vision is also closely aligned with Sláintecare and shares the Sláintecare vision, the right care in the right place at the right time. It aims to create easier access to multidisciplinary, user-centred supports at primary care level, focusing on early intervention. The HSE Crisis Resolution Services Model of Care also aligns with Connecting for Life, the national strategy to reduce suicide. We know that crisis resolution services are a key suicide prevention and intervention tool. A crisis is a very individual experience for the person or family experiencing it. However, a crisis is also short-term. A mental health crisis occurs when a person has a significant problem, a sequence of events or significant mental health issue resulting in them becoming emotionally overwhelmed and just not being able to cope or be in control of their situation. Such circumstances are not uncommon, but neither are they insurmountable. People can and they do recover. This model of care aims to provide brief, person-centred intensive supports in people's home and community in a timely way to assist them in their recovery and as an alternative to hospital admissions. Crisis resolution services are community-based multidisciplinary teams which provide rapid assessment and intensive support to individuals who are in mental health crisis, working rapidly and cooperatively to help people in a mental health crisis. They provide an alternative to inpatient care when not needed, while also ensuring that referral pathways exist for service users who do need more acute supports. It is intended that there will be an integral part of each community mental health team into the future, providing 24-hour advice and assessment for people presenting in crisis associated with a known or suspected mental health problem. The crisis response service is time limited, it's person-centred and it's recovery focused, aiming to utilise the service user's own lived experience and strengths as much as possible, and closely aligning it with the core principles of Sharing the Vision. Self-agency and person-to-person support are both central to the crisis resolution model of care and to Sharing the Vision. By early and effective interventions in times of crisis, we can improve outcomes for service users and empower them to overcome challenging periods in their lives. To date, there are 5 pilot learning sites open in CHOs 1, CHOs 4, 5 and 6, with a 5th site due to open by the end of this year in CHO 3. In addition, crisis resolution teams support solace cafes to offer an alternative response to inpatient admission in a time of crisis. Crisis cafe teams provide an out-of-hours friendly and supportive community crisis prevention and crisis response service in the evenings and at weekends in a cafe-style, non-clinical and safe environment. The cafe service Solace Cafe supports individuals and their family member carers to manage their mental health and well-being and link them in with relevant HSE and statutory providers. Solace Cafes are in the process of being rolled out across 4 CHO pilot sites, with 1 cafe already open in CHO 4, which is Cork and Kerry, and the remaining 4 learning sites progressing the development of service level agreements with community partners. There will be an independent evaluation undertaken of the pilot implementation of crisis resolution services over the testing phase after 18 to 24 months, in line with the standard operating procedure and the model of care. I welcome the speakers today from Sligo Crisis Resolution Services, and I would like to take the opportunity to congratulate Dr. Elizabeth Gethens, consultant psychiatrist, and her team on winning one of the 2023 HSE Service Excellence Awards. Given that the model of care for crisis resolution services was launched in May of this year, it is to their team's credit that the service is already in operation and to a standard acknowledged by the Service Excellence Award. So very well done. In conclusion, I would like to reiterate that the government remains committed to developing and advancing mental health services available in Ireland. In Budget 2024, I secured €1.3 billion for mental health, a record funding level and an increase for the 4th year in a row. I would like to thank you all for attending today's webinar and Dr. Gethens for highlighting the valuable work undertaken by this new model of care and the innovative approach to mental health that the crisis resolution services provide to users. So thank you very much for your time and enjoy the rest of the conference.
Thank you very much, Minister Butler, for your support for our work and indeed for the implementation of Sláintecare. Before we begin our exploration of the project, I am delighted to welcome Professor Philip Dodd. Philip is the Mental Health Policy and Clinical Specialist at the Department of Health. Professor Dodd, you are very welcome. Thank you for joining us this afternoon.
Thanks
Philip,
so much,
you're very welcome. Would you like to outline what your role in the Department of Health is and how you're working towards the Sláintecare goals of right care, right place, right time in a mental health context?
Thanks so much, Gráinne. And just before I begin, on behalf of the Mental Health Unit of the Department, I would like to thank Sláintecare and this Sláintecare webinar series in really showcasing a really important mental health service innovation that's aligned with our mental health policy, sharing the vision. So yes, I work in the mental health unit of the department. I've been working as a policy and clinical specialist since the beginning of 2021, and I was seconded in to the department from the HSE, where I had been working as a psychiatrist and also trained as a psychotherapist and also a clinical researcher. But for many years, I'd worked as a clinical director. And then before my time in the department, I had also worked as the National Clinical Lead for Mental Health and also working in the National Office for Suicide Prevention as a clinical advisor. So I've had the opportunity before coming to the department of working across a whole range of clinical services, very much focused in on mental health. So to get an opportunity to come to work in the department just after the launch of our new National Mental Health Policy, Sharing the Vision, presented as a huge opportunity, both personally, but I also felt professionally as well, in that I felt I am well positioned to maybe push forward some of the implementation tasks as set out. So I work in the mental health unit of the department, so it's one of the units, and the unit is tasked with implementing, as I've said, sharing the vision, our national mental health policy, but also Connecting for Life, our national suicide and self-harm reduction strategy. I also work very closely in the unit in our development of legislative reform. So we're currently developing an amendment bill to the Mental Health Act. And I also work very closely with across our international engagements with World Health Organization and EU as well. And I've also had the opportunity of working across other units and divisions in the department, including very closely with the Women's Health Task Force, the International Unit, as I've said, the Research and Statistics Unit, the CMO's unit, or the Chief Medical Officers Unit in particular in Sláintecare, and also in Healthy Ireland. As regards how our mental health unit, and I guess more specifically our mental health policies, supports the implementation of Sláintecare, well, Sharing the Vision is very much allied to Sláintecare, and it was developed after Sláintecare had been developed. So it very much has an ambition of providing a whole of population mental health service and reforming our mental health service so it delivers the right service to the right person at the right time. So they're very closely aligned. And in fact, the Crisis Resolution Service is specifically called out in recommendation 24 of Sharing the Vision. Sláintecare obviously requires a whole range of enablers to enable that type of care to be provided in the community. So Sharing the Vision also has very key recommendations that enables us to engage with the Department of Housing, the Department of Social Protection, and the Department of Education, as some examples of other government departments who are also key enablers to support people on their recovery from mental health difficulties, again, as close to the person and as person-centered as possible.
Right, really interesting and fantastic to hear the scope of your own background and all that you're bringing to the task. What have you seen are the major achievements to date then in delivering mental health services? And then what are the future priorities?
Yeah, so Gráinne, I guess the previous mental health policy vision for change, it actually delivered quite a lot of mental health service reform. It very much embedded what community-based mental health services should look like. It very clearly defined and focused in on the development and enhancement of community mental health teams. It also led out on a number of capital infrastructural changes, very much moving and improving the physical environments of acute treatment. So, for example, our new central mental hospital or National Forensic Mental Health Service opened last year at the new site at Portrane. That replaced a Victorian service in Dundrum.
Yes.
So that's very much was a key, and it's easy for us to forget some of those critical environmental improvements. We've obviously lots still to do to improve the physical infrastructure of our acute services. Other major achievements, I think Sharing the Vision is a very important policy in that it is a whole of population approach. So it's a public health approach to mental health. So it very much cites mental health as relevant to the whole population. So we all need our mental health to be promoted.
Yes.
And then we also need access to early intervention if we do require supports. And we also then obviously need access to specialist services. So the ambition of Sharing the Vision is across all of that. It has at the center of it a very clear, independent monitoring system for implementation. And that's through the National Implementation and Monitoring Committee that's chaired by John Saunders. And I guess with regard to its scope on the mental health promotion side, the policy has been instrumental in, for example, supporting the HSE's recently published and now in implementation Stronger Together mental health promotion plan. For example, at the centre of that is the whole provision of social prescribing across the country. On an early intervention, we're developing a number of digital mental health services that really enables the citizen to take their own mental health under their own control around early intervention. And then on the specialist mental health services side, we're developing a whole range of clinical programs. So we've 5 national clinical programs in mental health and other associated service improvement projects. And I just call out maybe one in particular, our perinatal mental health service, model of service, has now associated with it 19 new clinical staff, and it's a service that's delivered across the whole country. So women in the perinatal period now have access to specialist mental health services that prior to 2019, no such service existed other than in the large maternity hospitals. So yeah, we have achieved that. We've also a huge amount of work to do. And I guess that's what the unit and the department remains focused on.
Great. And I know just you mentioned the social prescribing. We showcased them. They were in receipt of funding last time round. And again, an amazing difference to small local communities,
Yeah,
these social prescribers, getting people involved in local activities and people
totally.
feeling, I feel great again and I'm connected to my friends and my community and their mental health really did improve. So great
Exactly.
example of the kind of stuff that has happened.
Yeah.
Yeah,
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 absolutely,
great.
Grania.
Okay, Philip, thanks for joining us. And I know you're going to join us later on for the panel, but for the moment, thanks again, and we'll see you later on in the afternoon. So, our focus today, as you've heard, is on the development of a crisis resolution team, mental health in Sligo Leitrim Mental Health Services, which, as the Minister has already told us, won an award at last week's Health Service Executive Excellence Awards. The award was in the Sláintecare, right place, right time category. So we were very delighted to see that. And this category is for projects that contribute to delivering Sláintecare goals. It demonstrates resilience and innovation in the Irish Health Service and is delivering person-centred care in an integrated manner. A really interesting and positive initiative. Congratulations to all. I'm going to talk now to Dr. Elizabeth Gethens, who is consultant psychiatrist, and we'll also hear from her team throughout the rest of the session. But first, let's watch a short video prepared for the awards about the winning project. In it, we'll meet some of the team we'll be chatting to later on this afternoon. But here is that video now for us all to enjoy.
I'm delighted to introduce our project, which was the development of a mental health crisis resolution team. The project was born out of a desire to provide an alternative service to people presenting with a mental health crisis in the emergency department. We've worked hand in hand with the Mental Health Change and Innovation Office, and we're very proud of the team and of the service that we've developed.
When someone is experiencing a mental health crisis, we can now offer an alternative to hospital admission or a presentation to ED. We will see the person on the day of the referral. We will see them in their own home and we will work intensively with them and their loved ones. This can mean actually seeing them 2 to 3 times daily, but these visits can be reduced as they progress with the crisis team.
We also support the early discharge of those service users still in crisis, who have been admitted to the adult mental health unit, providing a realistic alternative to inpatient care. We work across extended hours from 8 AM to 8 PM, 7 days a week, so that service users and their families are fully supported. We have one phone contact number and one email address for ease of contact.
We've a very experienced multidisciplinary team with a broad range of skills and expertise. This helps us to meet the treatment and care needs of service users.
We have been very clear from the beginning of the project that this service is available to everybody who needs it in our catchment area, which is Sligo, Leitrim, South Donegal and West Cavan. This is a very rural community, but we feel very strongly that no one should be denied a service because of where they live.
We can already see that our service is having a positive impact. It has taken some of the pressure off admission beds, our community mental health teams and the emergency department.
The most gratifying part of our work comes from the feedback of the service users and their families.
We are delighted to receive the recognition that this award brings to rural and mental health service provision. We look forward to consolidating and growing the service into the future.
Great, and a great overview to start with. Dr. Gethens, you are very welcome and congratulations again to you and the team on winning the HSE Excellence Award. Would you start maybe telling me about the background to the project and what was the problem that you set out to solve?
Okay. Thank you very much, Grania, to you and the team for hosting us today. Perhaps Tom could put up the slides there. The team and I are delighted to have the opportunity to talk about the work that we've been doing to date in setting up a crisis resolution team in Sligo Leitrim Mental Health Services. Next slide. Our service is guided. Next slide there, Tom. Thank you. Our service is guided by the philosophy set out in the national model of care, and it's there on your screens for all of you to see. And I think if you give it a minute, it's a big ask, but is also very rightly what all of us should be working towards. And there's a huge amount carried within that statement itself. Next slide. Our journey really began. It was born out of a frustration, really, at seeing the increase in demand for services, for mental health services, and particularly the increase in demand in our local emergency department. Certainly, with my liaison hat on, I was very conscious that we were seeing a 250% increase in mental health attendances to the emergency department. And we were also very aware that a substantial number of those presenting could and should be seen and managed within a community setting. So we became involved in the national steering group and developed, I was delighted to be part of the group that developed the national model of care and the SOP. And I wanted to particularly pay tribute to my colleagues, Sinead Hardiman and Michelle Butler in the Change and Innovation Department, who guided this process through quite a long gestation period, or certainly it felt that way at times. But it was great to actually get as far as having a model of care and SOP. From our point of view, we launched a very limited service on the 5th of December 2022. So we had our first birthday the other day, along with Hugh and Joan. It wasn't their first birthdays, but we were initially restricted our area to the Sligo town catchment area only, but very quickly opened up on the 9th of January earlier this year to referrals from other community mental health teams. And on the 13th of March, opened up to referrals from GPs. So by the mid-March, we were in a place where we were able to take referrals from all those who were appropriate to refer to us. And we'll talk a little more about this. It's also important to acknowledge that we had significant support from senior management within Sligo Leitrim Mental Health Services. And we have a local steering group which continues to oversee the project. Minister Butler referred to the national launch of Model of Care in Sligo on the 26th of May 2023, which was a fabulous event for all of us. And of course, we were delighted to be awarded the HSE Excellence Award last week for Right Care, Right Place and Right Time. So it's been a very busy, but a very positive year. Next slide. We're just going to put up a couple of photos now from the launch of the model of care, which Minister Butler attended. And I think it's important to note that this was held in the Clayton Hotel, and this used to be the old local asylum. So there was a lovely circular moment had there to see a comprehensive community-facing service being launched from what was the old institution. Next slide, please. Just a quick glance now at our the Sligo Leitrim Mental Health Service catchment area. We referred to it briefly in the video, but we cover the whole of Sligo, Leitrim, South Donegal and West Cavan. So it's quite a geographical, it's quite the landscape. Our team base is in Sligo. On another circular moment, we are currently operating out of what was the old female admissions ward in St. Columba's. So our team base is in Sligo, and we will travel to whatever part of the counties or our catchment area is needed in terms of seeing somebody. And if you look at that on the left of your screen, you'll see Enniscrone, which is 56 kilometres away. The Lahi line up in Donegal is 59 kilometres away. And places like Carrigallen is 92 kilometres, Carrick and Shannon is 56 kilometres away. So there's quite a bit of distance covered, but to date we're very proud of the fact that we have not had to turn anybody down who has needed our service because of where they lived. Next slide. I'm just going to present a little bit of data now. I'm not going to go, I'm not going to go through this too much or bamboozle with too many figures. But just in terms of activity, since opening, we've assessed 224 referrals to our service and accepted 160 people onto our caseload. It's important to think for a minute about the reasons why some people were not accepted onto the caseload. And for a lot of people, the assessment process itself was enough. Sometimes we would send people back to their GP then with advice on signposting or hook them into other more appropriate services within the community. There were a number of people who chose not to engage, as is their right, and engagement is a key requirement for the service. And there are also a number of people who needed admission. And while initially we thought this felt like a failure on our part, but actually they just showed that we're being referred the right people. And for those people whose admission we facilitated, often we've been able to take the trauma out of the process of admission to hospital or the use or have the need to use the Mental Health Act. Next slide. We looked at some very brief data from the first 100 patients, if you like, that we had on our caseload. And you can see that a lot of the referrals came from the liaison department, mostly presentations to the emergency department, but also from our GP colleagues who are increasingly using us, and we're delighted to see that. And as you might expect, a significant number of the referrals were people who were experiencing thoughts of self-harm or suicidal ideation. We also had lots of people with anxiety and depressive presenting symptoms. But of course, a lot of these people would also have significant psychosocial issues. And again, one of my colleagues will talk a little about this later on. Next slide. In terms of our discharge pathway for this 100 patient cohort, about half of them went back to the community mental health team. A number needed admission, a number went back to the psychiatry of old age team, and we do take referrals past the age of 65, and a significant number went back to their GP. Next slide. We also wanted to get a sense of the impact that we were having on service provision, and we looked at some local data. Now, we're in the fortunate position of being able to compare what we've been doing with 2022 figures using our liaison mental health database. So from a service perspective, already we have seen a 20% reduction on the number of admissions from the emergency department to the adult mental health unit, because they now, that cohort of at-risk patients, we now have an alternative pathway. We've been able to support the early discharge of 26 service users from the adult mental health unit. We've been able to reduce some of the demand on the acute demand on community mental health teams, and that frees up resources in terms of time and pressure, because we've seen a 25% reduction in the numbers referred from the emergency department to the community mental health teams. They're coming to us instead. So a lot of that acuity has been taken out. And interestingly enough, even though we've only been open to GPs for 8 months, in that 8-month period, we've seen a 25% reduction in the numbers of people referred into the emergency department by GPs. Now, I know that there's a little bit of scientific rigor needed in terms of these are just trends that we're seeing in our own practice, but I think it's very positive that we were able to see this already at a very early stage of this project development. And I look forward to telling you a little bit later on in the webinar about some of our future hopes and dreams and plans going forward. Thank you, Grania.
Great, and thank you so much. I'm really taken with some of those, 20% reduction in admission to the adult mental health, and then the early discharge, which is so important for people they need that kind of acute intensive care to get through it and get
Absolutely.
out the other side. So very impressed with those. And we might talk later on about the importance of the extended hours, but also the rural. I'd like to talk a little bit more
Yes.
about that with you later on, because it has its challenges and you seem to be meeting them. So thank you for that. We're going to meet some more of your team now, and we're going to have a look at the crisis resolution team itself. Enda Moylan is the team lead. Enda, you're very welcome this afternoon. We saw you there on the little video, and we'd like to talk a little bit more to you. Enda, would you talk to us about, the crisis resolution team? What is it? Who is it for? And I suppose, importantly, who can refer in?
Thanks, Grania. Yeah, the crisis resolution team were based on the national model of care. What is the crisis resolution team? We're basically a community-based MDT. We provide multidisciplinary assessment, intensive support to people who are in a mental health crisis. The team can provide an alternative to inpatient admission in the service user's own environment and are in a community setting, with the active involvement of service users and their families, carers and supporters, interagency liaison with local partners. Support is time limited, providing intensive intervention and support for an average period of up to 6 weeks. The service will be service user centred and also recovery focused. Typically, this entails a range of therapeutic approaches, including medication management, psychological interventions, peer support, and evidence-informed family or social interventions, utilising the person's own lived experiences and strengths. Next slide. So we provide brief and intensive multidisciplinary community-based assessment and treatment for individuals experiencing acute crisis. We provide a multidisciplinary, holistic, comprehensive health assessment and crisis intervention care plan, focusing on the immediate psychological, physical, social, occupational needs to de-escalate or contain the crisis for the actual individual. We deliver a crisis response service user care pathway that will empower and enable those using the service to take an active role in their care and recovery process, and to enable active involvement of the family and care significant others. We build, increase and enhance the service users' resilience to enable them to respond to and manage the current crisis and any other crisis that may occur going forward. We ensure timely crisis response to all appropriate referrals, ensure that individuals experiencing acute crisis are supported and attended to in the least restrictive environment as is clinically possible. Next slide, please. We act as an alternative pathway to hospital admission. We provide a time-limited intervention, the time being up to 6 weeks. This that has sufficiently flexible to respond to differing service user needs. We support the service user in learning through experience with the aim of preventing future crisis through post-event reflection on the crisis. We facilitate early discharge options from the acute inpatient wards as a transitioning support to the community mental health teams. We develop collaborative partnership working arrangement with other services to enable appropriate alternative pathways to the admission. Next slide, please. So crisis resolution team provides a service for people over the age of 18 experiencing an acute mental health crisis where it is determined the needs of the service user could be met more effectively in the community through a rapid response. It's time-bound intensive intervention rather than an inpatient admission. A crisis resolution team user may be presenting in crisis or in need of a short period of intensive community treatment. However, the service user needs to be willing to engage with the team in order to avail of the service. And next slide, please. The actual referral pathways, who can refer to the crisis resolution team. We receive referrals for service users, and again, once they're over 18 years of age, GPs can refer to us, any member of the community mental health teams, a member of the liaison psychiatry team in the CRS learning site location hospitals, authorised officers, or mental health inpatient units.
Very good. So I want to talk with you a little bit, and I might leave it till the panel if we can. And I want to talk to you a little bit later on about the service user voice. So I'll come back to that in the panel. I'd also like to say to our viewers and our participants today, you can send in questions using the chat function. We've had a number in already, but if people have further questions or comments, please feel free to use the chat function. So thanks a lot for that, Enda. I'll come back to you in the panel. Let's now hear from, thank you. Let's hear from Joan. And Joan Epping is the clinical nurse specialist. Joan, will you tell us about the day-to-day work of the team, if you would, please?
Okay, so just to start off, our hours begin at 8 a.m. We work a 12-hour shift, 7 days a week. We take referrals Monday to Friday from GPs, liaison service, community mental health team, and the mental health unit. And the weekends, there's 2 staff members that work the same hours. Right. So the day usually starts when we all meet and we discuss. We have a board, clients' initials on it, and we discuss each client on the caseload and then any new referrals that have come in. First thing, the new referral will always have first priority. Each client is discussed with regard to the following issues: their current risk, the main issue, what stage their crisis is in, and also how long they've been on the team. So that kind of keeps us on track. Then from the above information, we kind of decide if the client will need 1 or 2 visits in the day. And we'll also look at, where they are in relation to if they're a long ways away from Sligo, and we plan on that. I suppose we're really lucky to have so many different people on the team that bring so much experience. So the decision who sees will kind of depend sometimes on the location, but also if there's a concern, say, as once the kind of crisis has settled down and we've kind of looked at the main issues, if something like, say, housing or occupational therapy is needed, so Roisin or Trays would maybe go to see them. So that's kind of decided the day of. Everybody on the team will always carry out an initial risk assessment, the initial assessment, and will complete the crisis and contingency plan. So, and then from there on, then we'll decide what the clients, what their needs are. So it's kind of worked around that. There's great learning in the team because we all work with so many different disciplines, and there's constant learning opportunities. And we're always, some of our staff members have attended DBT courses and CBT course coming this January. Then the other thing we're looking at is supervision, and that'll help us just kind of to look back and reflect on cases that are quite difficult. And we do a lot of discussion during the day as to how things are working. We are very flexible. We can chop and change to suit the client's needs. We, on weekends you'll have kids at home, so we can organise to see people outside the home when the kids are there. So that's our day.
Great. And I mean, I think the 8 to 8 is a great service. As we know, people don't have incidents, 9 to 5. So it's great to see that the extended hours. And as you say, the multiplicity of the multidisciplinary nature of the team that people have that they can get supports from is just super. Thanks a million for that, Joan.
Thank you.
Thank you. Next, I want to hear from Ray. Ray Slevin is the clinical nurse specialist. Ray, earlier Enda spoke about the importance, we mentioned the importance of the service user voice and the patient-centred approach. Can you talk to us about the impact of the service on the person who's going through a mental crisis and their carers or family?
Sure. Thank you, Gráinne. Yeah, the service user is at the center of everything that we do. The service is for them and their families, and it's important that we're mindful that the service has an impact on what they need and deserve. I suppose that's really the most important part of it for us.
Yeah.
We're in a privileged and rewarding position as care providers to be able to care for people in their own homes as an alternative to hospital admission, and it's very often we reach people who are in very rural parts of our catchment areas, as Liz was saying earlier. We've got quite a large catchment and also very rural, and so they might have historically found it very difficult to access mental health services in the community. Our multidisciplinary approach allows the team to address a range of complex health impacting issues in the community as they arise, and enables the service users recovery in the comfort of their own homes, and it helps build their resilience to manage in the community. One of our main aims is to support the service user to stay out of hospital during their mental health crisis, but on occasion where the service user's their care needs become unmanageable in the community, we do support the service user's admission to hospital, and often with the relationship that we've built up with them, we do that without the use of the Mental Health Act, which is very good. We support people with their transition out of hospital. Liz mentioned that earlier, and where the service user may still be in crisis, but the risk may have reduced enough to shorten their hospital stay and to be able to engage with the crisis resolution team. When we discharge people from the crisis resolution team caseload, we send a care opinion survey within 2 days of discharge, and this feedback is unfiltered and unstructured. In the new slide, so in this slide, you'll see that so far the feedback that we've received has been very positive and encouraging, and it allows us to reflect on the service that we're providing and to make any changes that need to be made as appropriate. So one of the comments that you'll see there from the slide is it informed us that by allowing for visits at times which suited the service user, it made engagement with the team less stressful, and the majority of our visits are pre-arranged with the service user. Also, the fact that team members take the time to know the service user's case prior to the visit means that they don't have to repeat the story
over and over.
Visit.
Yeah, great.
Yeah. And that's feedback that we've used to be integral to our daily handovers and our communication during the day. Others have found support in the initial stages of the crisis to be really beneficial to their recovery, in the sense that the constant support means that they don't have to stay in hospital. The feedback that we've received, it's not only from service users, but also from family members and carers. And one of the comments that you'll see there, the family found it reassuring that the crisis resolution team were at the other end of the phone when needed to discuss any concerns or issues they may have in helping navigate them and manage through their loved one's crisis.
Brilliant. And I love that idea of the care opinion going out so quickly. And that then can feed into changes you might need to make, or if there's something that's not quite working right, you're getting it back immediately and can make the change. That's great, Ray. Thanks very much. We'll talk to you a little bit later on. Super. I'm joined now by Roisin Carnes, who's the Senior Occupational Therapist. Good afternoon, Roisin. You're very welcome.
Hi, Grania. Thanks for having us.
Very good. Listen, Roisin, talk to us about some of the lessons and the learning. We were just talking there with Ray about, hearing back from the users of the service and being able to use that feedback. So what have some of the lessons and the learnings along the way been, maybe from the users, but also from yourselves delivering the service?
Yeah, for sure. So I suppose from a documentation point of view, early on it became apparent we needed a clear document pathway, as most people we see on the day of referral, which means that we don't initially have access to their full clinical file. So it was a priority that we all knew what documents needed to be completed and when. We actually opted to go with paperless files. So our service user data is stored on a file share, which can only be accessed by the crisis resolution staff team. Each patient has their own folder where we store key documentation, including their clinical notes, which we can update contemporaneously. We have found that having our files accessible by computers has supported us with keeping our notes and documentation up to date, despite the amount of time that we are off base and all the travel we have to complete across the CHO1. Our discharge documentation, we found it's been operating best to kind of complete it and stick to completing it within 2 days of a discharge to ensure a smooth transition. As part of learning, being a learning site, we collect data on all referrals and service users accepted onto our caseload. All of our daily contacts are recorded, and the future is the hope in the future is that this data would be used as part of some research. And already it's been helpful for us to be transparent with the wider mental health service locally to kind of showcase the wider benefit that our team is having on other and impacting other services. At the moment, all this data is being collected on a very large Excel sheet, but in the future, the plan is to switch to a purpose-built software. With regards to relationship pathways, they've been crucial, especially with regards to referrals and getting information about the service users that come onto our team. Early on, the CRT, when we were established, we prioritised meeting with local GPs and each local community mental health team, including psychiatry of later life, mental health and ID services, early intervention psychosis and addiction services. In the next year, we hope to meet again with our colleagues to kind of feedback and update about the progress our services made and kind of their own feedback to us as well, we feel would be helpful. Again, these relationships have been really important when it comes to planning discharge and to ease the service users transition back to the care of either their GP or their treating team. This year we have also met with the local Gardaí to establish some links, and we hope to complete some teaching with the Gardaí next year in relation to our role as part of the mental health service. With regards to boundaries and sticking to a 6-week intervention, according to our data, most people have tended to only require a 3 to 4 week intervention. However, we have had some, we have had some service users who we felt we could have continued to work with on a longer term, given more intensive support, but we have been kind of strict in keeping with the 6 weeks time frame because we found it gave us the capacity to keep up with referrals, new referrals coming in, and to keep very focused on our role and to stay aligned with our model of care and to ensure that we're completing crisis work and not the work of long-term intervention. I believe the longest we've gone over is maybe 1 day past the 6 weeks. Right. So it's not too bad. Okay. An issue of so some of the issues of that's come up from another thing was around the area of authorised officers, and the role within the team needing to be clarified. So to date, 5 of us have completed training as authorised officers, and the difference, I suppose, between being asked to carry out the role of an authorised officer independent of crisis team work and how it may impact on the availability of the service and the potential to use the role of the authorised officer in relation to someone who's already on the caseload of the crisis team. So this is currently being discussed with our mental health, association and minister and senior colleagues to kind of further explore where that's going to go in the future. Day to day, we see the impact of the housing crisis again and again in our work, and it's across all levels of income, whether people are homeless or at risk of becoming homeless. The impact is huge on people's mental health and their well-being. Another theme that has come out kind of from our work is a small cohort of adults who feel that they have ASD traits but do not have a diagnosis. And the difficulty we kind of face, ASD, yeah.
What does
autism
ASD
spectrum
mean?
disorder.
Okay,
sorry,
right,
autism
thanks.
spectrum disorder.
Yeah.
Yeah. And on discharge, the lack of public adult autism spectrum services with regards to, someone getting an assessment or intervention as an adult is just a difficulty kind of we run into with people, as there's a lack of it at the moment. In terms of flexibility, we have to allow for frequent changes in our working day due to referrals, and as Joan said earlier, working around the lives of our service users and the unique challenges that people face, and all the things that we wouldn't usually consider to be part of the job description. So they're the kinds of things that have tended to come up for us.
Exactly, as you say, the job description never covers everything that you end up doing.
No.
That's great, Roisin. Thank you so much. Can I invite? That was really super. Can I invite the rest of our panelists to come back on? And I think we've about 10 minutes or so, and we are getting questions in, which is super. But I want to go back maybe in the first. So Elizabeth, Professor Philip Dodd, Enda Moylan, Joan Epping, Ray Slevins, and Roisin, you stay on. Coming back to Dr. Gethens, if I may come to you first, we've heard about hugely interesting project, and great to hear from the individual members of the team and the work that's going on there. But briefly, what are the next steps?
Okay, thank you, Gráinne. Well, there's a few things that we need to consider. I mean, the first is that we consolidate the progress and the work that we've done to date, because it has been quite the whirlwind year. The other thing that we're doing at the moment is looking at creative solutions locally that would allow us to start doing weekend assessments, because we do feel that if we had the resources to do weekend assessments, we could lessen further the pressure on the emergency department, but also the unit. We are planning on getting a peer worker to join the service. We know that the funding has been agreed at CHO1 level. So it's just about
that was one of the questions that just came in. Yeah, fantastic.
That will also tie very much to as well that we've just been through the process, and we have a successful candidate with whom we're hoping to develop a service level agreement to launch the Solace Cafe. So hopefully Q1, Q2 of 2024, we'll get that community resource up and running, and hopefully that will take some further pressure off the emergency department. And then lastly, we're looking forward to being part of the National Research and Evaluation Project. So as every good politician says, lots done, but lots more to do.
More to do, exactly. Super. I'm going to take some of the questions that have come in, if people are okay with that. Again, looking, one has come in, Enda, just specifically around what would be the most common acute crisis seen by the team in the community, and can it be taken? So I suppose, acute crisis, and can you actually take that in by the team?
Yeah, we take our referrals. We're pretty responsive regarding the referrals. As I think Roisin mentioned, we just have one point of contact. We receive an email, but we insist on a phone call into the team to describe the nature of the crisis, where they are, and how quick then we can respond to. So yeah, we respond very, very quickly to an acute crisis. Like the referral pathways, we've asked for, that a general practitioner, the community mental health teams actually refer to us, so we know that the person is literally in crisis, that it's not a row they had or whatever. So we respond very quickly to that. I suppose the majority of the more serious referrals we get would have that element of suicidality, self-harm. They would be pretty serious, not necessarily, acute psychosis or something like that. It can be just a crisis in the home, somebody that just can't cope with the circumstances that's around them. So we'll respond. We absolutely try and respond as quickly as possible, and depending on how Joan described our day, but we can put our day on hold if we get a crisis that requires our attention. So yeah, we'll respond as quickly as possible.
That's super. And in terms of Philip, there's one came in there, maybe is for you. Sharing the vision makes reference to the importance of trauma-informed care. Is this something that's on the agenda for integration within mental health services? As the questioner says, one might argue that trauma accelerates the development of crisis.
Yeah, thanks, Gráinne. It's a really, really good question. When we were developing Sharing the Vision, we did a whole series of public town hall type meetings. And the whole way in which people engage with acute mental health services through emergency department came up as a key issue. And a real focus for improvement, and hence part of the focus of the policy is exactly what we're talking about today: the development of alternative pathways for acute treatment, and that links very much with people's sense of trauma and avoiding traumatic reminders or traumatic experiences. And part, I think, of what exactly Liz and her team have described is giving people choice, giving people and seeing them as fast as possible, and enabling them to receive treatment quickly. The full model of care includes integration with crisis cafes, which are really peer-led crisis cafes that really enable people with lived experience to support as appropriate others experiencing a mental health crisis or mental health difficulty. So that's another example of really responding in the service design in a trauma-informed way. And I guess finally, the way in which we deliver mental health services in the HSE has at its centre mental health engagement and recovery. So the whole voice of lived experience is actually embedded in the whole management structure of each CHO. And finally, within Sharing the Vision, we have a reference group of service users that really works very closely with the whole way in which the policy is rolled out and monitored. So really hearing the voice of lived experience is really influencing the way in which we design and implement the policy.
Great, thanks, Philip. Particular question here for Roisin, if I might. Can Roisin please elaborate on the role of the OT in a crisis, maybe giving an example of an intervention? People want to know exactly what you do, Roisin.
Yes, so I suppose, look, at my role in the crisis team is very different. I came previously from a community mental health team. There is an element of key working involved with the crisis team, which means that I complete initial assessments like any other member of the team. And then I suppose as needs arise, I would prioritise to see certain people who might have occupational needs. And I suppose the types of people, it's quite nice in a way because some of the people, maybe this is their first instance of contact with mental health services. And in often cases, these are people who would not typically be referred to or receive community mental health occupational therapy. So these could be people who are working quite high level jobs. The interventions, I suppose, in those instances might be kind of task prioritization and looking at lifestyle balance and kind of role prioritization. So in other instances in community OT, you might be trying to expand somebody's roles, you know, and task demands. And in other cases, particularly in the crisis team, you're trying to get somebody to pare back to, you know, not be taking on every demand and kind of just, core stuff and things that really go with their values. I suppose time and again, what's come up a lot is some sensory-based challenges with some people and supporting people to kind of regulate themselves when, I suppose, in crisis. And what I've kind of found is a lot of times maybe people don't have sensory processing challenges, but in crisis, things can kind of get dialed up a little bit and they can have challenges with regulating themselves. So looking at the routine and seeing where could we establish some things that might support them to feel calmer alongside, I suppose, the other elements and kind of therapies that the other team might be working on them with, like cognitive based strategies. And I suppose a lot of it would be focused on people's routine and kind of as well grading and trying to establish a remotivational process with some people trying to re-establish their routine quickly so that they can get back to work or get back to doing the things that are important to them.
Yeah, great, really clear. Thanks, Roisin, for that. Elizabeth, I might come to you with one that came in around, you know, people really applauding the unnecessary ED attendance and your figures there, and wondering, is there a possibility for the National Ambulance Service practitioners to be able to refer in?
The wonderful thing about a pilot project is that anything is possible.
Anything is possible. I love it.
And you know, this project is certainly open to any channel that will take pressure off the emergency department. Now, as things currently exist, that's not a pathway, but it's something that can come into the learning. And I'm aware as well that the National Ambulance Service have been involved with, oh, damn it.
That's all right.
Have been involved in discussions with the National Steering Group. So the ambulance service did have a voice in the design of the model of care.
Yeah.
I might touch on just one or two other issues because I'm aware we're just getting very tight on time.
Yeah.
With regard to the question regarding perinatal mental health services, the issue there is we have Sligo is a spoke site, and one of my other hats is kind of with an interest in the perinatal mental health service. We would certainly take a referral from the mental health midwife or from any of the community mental health teams if that was appropriate. And there's also a question about the fact that our service is 8 a.m. to 8 p.m. 7 days a week, but we only do referrals Monday to Friday. The issue on Saturdays and Sundays at the moment is one of resources. We have 2 people on at the weekend and a huge place to cover. So their job is maintaining the caseload as is current. But as I said earlier, we're looking at trying to get some creative solutions to actually monitor, to increasing our capacity to take to do assessments at the weekend.
Great, great. And I'm afraid we have run out of time. What an interesting project and great work. And it was lovely to meet so many of the team. And I particularly liked the voice of the service user being able to tell us what's going on for them and how well it's working. I'm sure many people on the call today, you know, many of our families, we have people who have experienced mental health difficulties. Wonderful to see this kind of pilot being rolled out and hopefully mainstreamed into the future, because it certainly seems to be working. Can I thank all of you for being on the call this afternoon? I want to thank the Minister for taking the time to do her piece and to be really supportive of the work that's happening. Philip, Elizabeth, your whole team, it was great for you to organise, to have them all on this afternoon, and the preparation that I know went into this. I want to thank everyone who helped to produce the session, Rosaline Harlan, Tom Duke. You can watch this webinar back or recommend it to your colleagues, and it will be available on the Sláintecare website. From me, Gráinne Healy, continue to stay safe and have a lovely Christmas. Thanks, everybody.